Good afternoon. My name is Aaron Rooker. I'm a project specialist with Quirk Healthcare, and welcome to today's Insights presentation on patient readmissions. We'll give folks a couple more minutes to join before we get started. Okay, we'll go ahead and get started. Thanks again for joining. For those of you that may have just joined, my name is Aaron Rooker. I'm a project specialist with Quirk Healthcare, and today's topic is going to be on patient readmissions. So how are you controlling? As you're aware, there's lots of trends in the industry that are sweeping towards how can we improve better care and promote more of a wellness approach, a preventative approach to healthcare. And one of those topics that's burning in the industry is hospital readmissions. So let's first start by looking at what is a hospital readmission. Well, a hospital readmission, CMS defines it as an admission to a subsection of a hospital within the 30 days of discharge from the hospital or from another subsection of that hospital. So that's the definition that CMS has placed on the hospital readmission or patient readmission. Just some quick facts. The Agency for Healthcare Research and Quality reported that nearly 20% of Medicare hospitalizations are followed by a readmission in 30 days. So that kind of yields that 90% of readmissions are unplanned. And just another fact, the Medicare Payment Advisory Commission reported that 4.4 million Medicare hospital readmissions may have been preventable. That translates to 75% of readmissions could have possibly been preventable. Now, the implementation of hospital readmissions reduction program has impacted the reported outcomes, and I'm sure we'll be seeing updates on that in the future. This is just a quick reference link below. Let's talk a little bit more about patient readmission statistics. So the JAMA study reported the following outcomes. 24.8% of heart failure patients were readmitted. 19.9% of all MI patients were readmitted. And then 18.3% of pneumonia patients were readmitted. And then just to give you a little background on JAMA, it's the Journal of American Medical Association. And what they did is they conducted a study from 2007 to 2009 for Medicare beneficiaries, and they were just reviewing the readmissions for patients with heart failure, MI, and pneumonia. And some pretty telling statistics. Let's just take a little bit of a look at the background. So Section 3025 of the Affordable Care Act establishes the Hospital Readmission Reduction Program. It requires CMS to reduce payments for IPPS hospitals with excess admissions and effective for discharges beginning in 2012. And now let's take a look at the hospital CMS's readmission measures. They adopted readmission measures for conditions for acute MI, heart failure, and pneumonia. It establishes a methodology to calculate excess readmission ratio. It established a policy for using risk adjustment methodology, and it also established applicable 3 years of discharge data that would use the minimum of 25 cases to calculate hospital excess readmissions ratio. A little later in the presentation, we're going to take a look at how they actually calculate that information. Let's talk a little bit about the CMS payment adjustment process. So the adjustment process, CMS determines which hospitals are subject to hospital readmissions program. They determine the methodology to calculate the hospital readmission, and then what portion of the IPPS payment is used to calculate the readjustment payment amount. The process for hospitals is to review the admission data and then submit corrections before the rates are made public. So translation, if you're able to catch possibly some corrections that need to be made ahead of time, it's in your best interest to submit that before they're out there to the public. So let's take a look at some of the formulas to calculate the readmission adjustments factor. The first one is the excess readmission ratio. And what that does is it takes the risk-adjusted predicted readmission and it divides it by the risk-adjusted expected readmissions. That's one of the ratios that CMS is using. The other is the aggregate payment for excess readmissions. And it takes the sum of the base operating DRG payments for AMI and it multiplies that amount by the excess readmission ratio for AMI -1, and then it also takes the sum of that base operating DRG times the excess of readmissions minus 4HF minus 1. And then it kind of follows that process for each one of the different measures. So it's just to give you a little look of the aggregate payments for excess readmissions. Then we're also going to take a look at the ratio. So it's going to take the number 1, and it's going to subtract it from the aggregate payments for excess readmissions divided by the aggregate payments for all discharges. And that will give you your base ratio. Let's look at the readmission adjustment factor. So for fiscal year 2013, the higher of a ratio of 0.99 will yield a 1% reduction. For 2014, the higher of a ratio of 0.98 will yield a 2% reduction. And for 2015, if it's higher than a ratio of 0.97, you'll have a 3% reduction. Let's look at some of the formulas to compute the readmission payment adjustment amount. So it's going to take the wage-adjusted DRG operating amount. It's going to take the DRG weight times the labor share times multiplied by the wage index, and it's going to take the other component of non-labor share times COLA if it's applicable, and it's going to take those two values and multiply it by the combined DRG weight. The base operating DRG payment amount, it's going to take the wage-adjusted DRG operating amount, and it's going to add it to the new technology payment if it's applicable. And we're also going to look at the readmission payment adjustment amount. So that's also going to take your base DRG operating payment amount, and it's going to multiply it by the admission adjustment factor. It's going to take that whole sum, or that whole calculation, and subtract it from the base operating DRG payment amount. So that's just to give you a little bit of the look behind how CMS is calculating those ratios and the adjustments. So in 2015, CMS IPBS is proposing this rule for 2015. It's proposing that it include 2 additional readmission measures. It's proposing to look at COPD and then the THA and TKA. So that's just what's proposed, and I'm sure we'll have more information on that in the coming months. So let's look at some common reasons for readmission. Healthcare market research or resources cite 2 of the most common reasons for the hospital readmission: their medication errors and its failure to see a physician. Some of the strategies that they're looking at, or one of the strategies they're looking at to reduce, is supervised home care visits after discharge. So, kind of evaluating what kind of supervision or what can be done after the discharge to improve and help reduce the readmission. And I think that's a recurring theme that we'll see. So what are other organizations doing? What is being done by some of the organizations, and what kind of strategies can be employed? Well, the Patient Safety Organization program has some strategies. The Agency for Healthcare Research and Quality advocates the use of the CSO program. So one of the programs is the utilization of common formats, and that's available for hospitals to review 30-day readmissions. Also, the RED, or the Re-Engineered Discharge Program. It's a free toolkit used to reduce readmissions by encouraging better communication between patients and clinicians. There's also a Project Boost program, and that provides resources to reduce readmissions in the elderly population. So they're gearing that specifically toward elderly patients. The PSNet program, it's a patient safety network. It shows how problems in hospital discharge process can lead to hospital readmissions. And then lastly, we have the STAR program, which is the State Action on Avoidable Rehospitalizations initiative. And it's the multi-state effort to improve care transitions. So these are some of the programs that the Patient Safety Organization is advocating that are available. So the assessment of a patient capacity. So one of the studies that the Mayo Clinic looked at is the knowledge and evaluation research is focusing on the assessment of patient capacity. It's evaluating the resources the patient has available to them when they discharge, and it's reviewing that against the physical and mental limitations of the patient when they're discharged. So when the patient is presented the discharge instructions, are the discharge instructions, is the patient mentally able to understand the discharge instructions and the follow-up instructions? So that's one of the components that the Mayo Clinic is evaluating to see if they're using best practices. The clinical and community prevention services recommendations. So they're looking at the support of national quality strategy for focus on improving cardiovascular health. They're looking at using the payment and reimbursement mechanisms to encourage delivery of clinical preventative services. So evaluating how clinical preventative services can reduce readmissions. Expanding the use of IT interoperability. Supporting the implementation of community-based preventative services. And then also reducing the risk barriers to accessing clinical and community preventative services. Also focusing on enhancing coordination and integration of clinical, behavioral, and complementary health strategies. One of the other strategies out there is the mini-cog quiz study. And the mini-cog quiz study is a study that was conducted by Cleveland Clinic. It suggests a 3-step mini-cog quiz that's completed by heart failure patients at discharge. And it may predict who will be readmitted or who may die within the next 30 days. The mini-cog test is the correlation for all heart failure patients. So in this test, the research concluded that 23% of the heart failure inpatients who completed the mini-cog had a high likelihood of cognitive impairment. The 30-day readmissions and mortality rate for those patients with a high impairment score were twice the norm with a rate of 47%. So based on the study conclusions, the recommendations were evaluated discharge locations, structured in-home support, and then incorporate the mini-cog test into the care routine. And below you can see the link with the full study if you would like to access it. The mobile apps and sensors. This was an interesting study that was that's taking place in Arizona. A select group of Medicare patients in Arizona are receiving trackers in their inhalers to determine how often medications are used. The study hopes to identify patients at the earliest stage of the attack of exacerbation with COPD. Sensors monitor medication usage and send location data to the smartphone app. If the patient's using medication more frequently or the rescue inhaler is utilized, an alert sensor is sent to a caregiver, in which case they can follow up with the patient. But this is just one of the examples of how technology can play a role in reducing patient and hospital readmissions. Some of the best practices that are recommended: improve communication, utilize strong interactive communication, or the utilization of EHR and HIE. Support care transitions, expanding the care beyond the medical community. So looking at opportunities in transportation services, or meal preparations, or cleaning services. Some of these services that can be offered to your patients as they discharge. Follow-up care, looking at missed follow-up appointments after discharge, and evaluating the length of time between those missed follow-up admissions. Some organizations are promoting 72 hours after a missed appointment follow-up with the patient to just check in and see how they're doing. And then I wanted to share this parallel coordination of care. And so Dr. Arian Goranowski, former director of the Heart Care at Home, is advising to focus on the patient as opposed to just the conditions for readmission. He proposes a partnership with quality skilled nursing facilities, and he evaluates that over 17% of all patients go to a SNF after discharge. Parallel solutions for care coordination, and I quote, a patient-centered rather than a condition-centered mindset is the best transition is key for moving forward. So that's the end of what we had to present today. Hopefully you're able to see some of the strategies that organizations are using to combat hospital readmissions and patient readmissions, and also hopefully you have a better understanding of how it's calculated, what it means, and how we can improve it to reduce that number in the future. We'll hold now for any questions that anyone may have. And while we're doing that, if there are any further questions after we get off, you can either reach out to Dan Holleran, dan.holleran@quirkhealthcare.com, or myself, aaron.rucker@quirkhealthcare.com. Well, thanks again for joining us and sharing some time with us today. Please join us for the next one. Thank you very much.